The surgical technique. The deformity model shows a right thoracic curve between L1 and T4. The area of instrumentation is also between L1 and T4. In the first step, pedicle screws are inserted into T12 and L1. They are inserted at the midpoint of the transverse process, as it meets the base of the facet joint. The bone at the entry point is penetrated with the pedicle awl. The hole is made deeper with the pedicle probe. The depth of the hole is measured with the depth gauge. It should be possible to feel the anterior cortex of the vertebral body with the gauge. In this case, the depth is 40 millimeters. The screw holder is attached to the USS handle. A pedicle screw of the appropriate length and diameter, in this case 40 millimeters long and 6.2 millimeters in diameter, is selected. It is attached to the end of the screw holder by turning the small knurled knob at the top of the handle. The length of the screw is checked against the depth gauge. The screw is inserted. After insertion, the handle and the screw holder are detached. At T12, part of the mammillary process needs to be removed before using the awl. The pedicle is opened in the usual manner, and a screw of the appropriate length is inserted. 3 pedicle screws have now been inserted at the base of the construct. A pedicle hook is to be inserted into T4. The pedicle feeler is positioned around the pedicle. The depth of the pedicle hook corresponds to the lowest line of the pedicle feeler. By removing bone to this level, a snug fit of the pedicle hook is ensured. The appropriate amount of bone is removed with an osteotome. The pedicle hook has a hole so that a USS 3.2 millimeter self-tapping screw can be inserted across the pedicle as far as the superior end plate of the vertebra. The pedicle hook is inserted and tapped into place with the hook positioner. The drill sleeve is inserted and a 2 millimeter hole is drilled. It's safe to start drilling only when the drill bit is touching the bone. The drill should penetrate the superior end plate of the vertebra. The depth gauge is used to check the wall of the hole and the length of the screw needed to reach the end plate. The appropriate 3.2 millimeter self-tapping screw is inserted. Pedicle hooks have been introduced into T4, T6, and the apical vertebra, T8. The T10 implant is a lamina hook. After the ligamentum flavum is removed, a Carrosson rongeur enlarges the space for the hook by removing some bone. It makes sense to use the lamina feeler for the preparation of the seat of a lamina hook. The appropriate size lamina hook is inserted. Experienced scoliosis surgeons might prefer to use a pedicle screw instead, as shown on the model. The concave instrumentation is shown. Pedicle hooks at T4, T6, and T8, and pedicle screws at T10, T12, and L1. On the convex side, a claw is constructed at the upper end of the deformity. At T4, the ligamentum flavum is removed. The opening is enlarged so that a small lamina hook can be inserted. A pedicle hook with a hook screw is placed at T5. The lamina hook with a screw holder and the pedicle hook are shown in place. The convex construct has been completed at the apex using a pedicle hook with a hook screw. The bending template for USS rods is now placed on the concave side and contoured to the correct sagittal plane. It's necessary to leave an extra 1.5 to 2 centimeters of length when trimming the rod to accommodate the lengthening of the spinal column during the correction. A template is also contoured on the convex side. The position of the superior lamina hook has to be taken into account, along with an extra 1.5 centimeters to allow for elongation of the spine. After trimming, the convex rod is approximately 1.5 centimeters longer than the concave rod. The USS 6 mm rods are now contoured in the sagittal plane to conform with the template. The two contoured rods can now be seen. It's clear that the convex rod is not as kyphotic as the concave rod. The concave rod is now attached to the L1 pedicle screw, which is instrumented with a screw holder. A 6 mm sleeve is picked up with the sleeve positioner, which incorporates a sleeve pusher that firmly holds the sleeve in place. The opening for the rod faces away from the holding point. The sleeve positioner is slid down the screw holder, and the sleeve is pushed down onto the rod. The pusher is retracted, and the positioner is removed. The 12-point nut is picked up with the spring-loaded L-handled socket wrench. If it's necessary to remove the nut from the socket wrench, the pillar at the corner of the implant tray is used. The nut is mounted. With the rod aligned correctly, the nut is fully tightened using the L-handled socket wrench, with a T-handled 5 mm socket wrench as an anti-torque device. The rod is inserted into the superior pedicle hook using the rod pusher. The sleeve and nut are then attached, but it's important that the nut be left loose in the proximal portion of the construct. To create the claw on the convex side of the deformity, the lamina hook is reinserted. The contoured rod is then placed between the two implants. It should be noted that the lamina hook is medial and the pedicle hook is lateral to the rod. A 6 mm sleeve is picked up with the rod introduction pliers. Once again, the extended foot of the sleeve pusher must be opposite the narrow lip of the sleeve. The rod introduction pliers are now slid over the screw holder. The rod is pressed into the slot of the lamina hook, and the sleeve is pushed down with the sleeve pusher to engage the rod. Once the sleeve is in place, the sleeve pusher is pulled back and the rod introduction pliers are removed. The nut is tightened using the L-handled socket wrench. The tightening torque has to be countered with the T-handled socket wrench. The rod is now inserted into the opening of the pedicle hook at T5. A sleeve and nut are mounted but not tightened. Before the nut of the pedicle hook is tightened, the claw has to be compressed using the rod-holding forceps and the spreader forceps. The lamina hook at T4 is snugged into place and the T5 nut is tightened. The claw is now complete. The rod is pressed from the lateral side into the apical pedicle hook. The sleeve and nut are mounted. It's important that the nut is left loose to allow the spine to be elongated during the correction. The process is repeated at L1. Again, the nut is left loose. The implants on the concave side are now attached to the rod. Beginning proximally, the rod introduction pliers are placed over the screw holder that is attached to the pedicle hook at T6. The rod is lifted to the opening of the pedicle hook using the distraction clip and the spreader forceps. After closing the rod introduction pliers, the sleeve is pushed down. Once the sleeve is in place, the sleeve pusher is pulled back. The distraction clip and the rod introduction pliers are removed. The nut is put on, but not tightened. The same technique is used at T10. The last hook is attached to the apex. This is the full construct. Now the upper and lower nuts are tightened. Holding the top and bottom screw holders, the singly instrumented levels can be further derotated. The two apical implants cannot be rotated since they are attached to the same vertebra. The screw holders are removed. Two pairs of cross-link clamps with 3.5 mm rods act as stabilizers linking the two longitudinal rods. The first pair is at T7, below the pedicle hook. The second pair is at T12. A 2.5 mm screwdriver with holding sleeve is used to pick up the cross-link clamps. The sleeve of each clamp is pulled back with the holding sleeve to attach the cross-link clamp to the 6 mm rod. When the clamp is in the right position on the rod, the holding sleeve is released. The 3.5 mm rod is inserted into the slot at the top of the cross-link clamp using the 3.5 mm rod holding forceps. The rod has to be pushed back so that the second cross-link clamp can be attached to the other 6 mm rod. Once the second clamp is in place, the rod can be inserted. The two set screws on the top of the cross-link clamps have to be firmly tightened. The second cross-link is mounted. When the construct is finished, the corrected spine has to be in kyphosis from T4 to T11, and in the neutral position or in slight lordosis from T12 on.